Good evening, all. I'm Dr. Chaitali Nikam, heading Infectious Diseases section at ThyroCare, welcoming all the participants and the panelists to the series of webinar conducting in collaboration with ThyroCare and Haystack on whole genome sequencing of TB diagnosis. In this webinar, Dr. Prabhudessai will be discussing about MDR TB diagnosis and also presenting through case studies how whole genome sequencing or NGS is enabling personalized treatment. To introduce Dr. Prabhudessai, he is having immense 25 years of experience. He is a fellow of American College Chest Physician. He is a member of European Respiratory Society and Indian Chest Society. He is a course director for bronchoscopy at IMMAST. Is running Pratibha Prabhakar Pulmonary Rehabilitation Center successfully in Goregaon, and he's done around 50 plus publication in national and international journals, and he has written a chapters in respiratory medicine books. I welcome Dr. Prabhudessai on board, sir.
Thank you very much. I think the pulmonary tuberculosis is and the multi-drug resistant tuberculosis pulmonary as well as extrapulmonary is a real challenge. And if you see last 3-4 years, every year there is some changes which is happening in the management of tuberculosis at WHO level as well as the national level. And these rapid changes indicates that a lot of activity is happening, and we are trying to come to some better methodology of diagnosing as well as treating tuberculosis, especially drug-resistant tuberculosis, because it has got a high morbidity, mortality, even the treatment failure rates are high. It's expensive disease to have, and as a nation, it is actually speaking, we have more tuberculosis, which indicates that we are not really speaking doing great job as well as health is concerned. The milestones which have happened from 2007 to 2012, where the solid cultures replacing the line pro assays and molecular studies, and then in 2012 to 2017, the national strategic plan introducing the CBNAT and universal drug susceptibility testing as a national policy, introducing newer drugs like Bedaquiline and Delaminid. And till 2020, we have the national strategic plan for even 2017 to 25 for ending TB at a national level, with introduction of TruNAT and universal drugs sensitivity test and shorter and longer multi-drug resistant tuberculosis regimen. So this all indicates that a lot of happening in the field of tuberculosis, especially in the national level. The top 10 causes, TB is one of the top 10 causes of death, and more than 1.7 billion people who are having approximately 22% of the whole population is suffering from tuberculosis, and globally 500,000 new cases of rifampicin resistant. Out of that, 78% have confirmed MDR TB. WHO aims that to reduce the worldwide tuberculosis incidence by 90% until 2035, and India is also trying to work hard on doing it before actually WHO targets. The Bedaquiline regimen, has got a good success rate up to 71%. Well, as well as the National Tuberculosis Control Program is concerned, if you see, there's a lot of happening in National Tuberculosis Control Program. A lot of NAT sites have opened from 2013 to 2019 and 2020, if you see. And a lot of MDR, a lot of tuberculosis suspect, presumptive TB patient, MDR and MDR plus rifampicin or rifampicin resistant TB or H resistant TB, XDR tuberculosis. We have every year we have trying to pick up more and more. And the real problem happened in the COVID time, when there is a sudden National Tuberculosis Control Program affected severely. And we found that the lesser amount of patients we actually picked up during that time. So this is something which is have hampered the tuberculosis control program significantly. The COVID is concerned. And the success rate of MDR and XDR patients on different regimens, I don't want to go into the depth of it, but if you see that the trend which is there to MDR tuberculosis is around 46 to 49%. If you see the bedaquiline regimen, you see that there is a very good amount of success rate, and You see here the H resistance success rate has, is showing increase. Surprisingly, the XDR tuberculosis has gone down during this 2019. So the National Strategies Program plan from 2017 to 2025 is basically to prevent, detect, and treat. Okay, and build challenges with build the infrastructure basically to take the challenges. So there is a challenges as well as prevention is concerned. There are diagnostic challenges and there are therapeutic challenges. To understand few things like infection, TB infection means these are the patients who have no symptoms, but just like a latent tuberculosis. Okay, they generally do not spread the disease. Right, tuberculosis disease is where the patient has symptoms. Okay, and that is where they generally have they are infectious to the others. Presumptive TB is referred to the person who have symptoms and signs of tuberculosis, and presumptive drug-resistant tuberculosis where patient who is eligible for rifampicin resistance screening at the time of diagnosis or during the course of treatment for either drug-sensitive tuberculosis or H monoresistant or polydrug-resistant tuberculosis, we suspect clinical failure and we suspect drug-resistant tuberculosis. 80% of the TB are pulmonary and 20% are extrapulmonary. Drug susceptibility testing referred to in vitro testing using either phenotyping methods. Remember, so phenotyping methods we do the susceptibility testing, while genotyping method we find out drug-resistant testing. That's a molecular technique. So this is a difference between the phenotyping and the terminologies are concerned. Monoresistance means only one drug resistance. Okay, a biological specimen is resistant to one first-line anti-TB drug only. Okay, so H monoresistance where it is resistant to rifampicin, INH only, and rifampicin is not confirmed or is sensitive. Rifampicin resistant is whose biological specimen is resistant to R detected using phenotyping or genotyping method, with or without resistance to any other anti-TB drugs. Okay, and in MDR we have INH and rifampicin resistant, and polydrug resistance means a TB patient who has got biological specimen which is resistant to more than one first-line anti-TB drug other than both H and R. So this is how the MDR is H and R resistance. Pre-XDR tuberculosis is Mycobacterium tuberculosis strain. These are fulfilling the definition of MDR or rifampicin resistant TB and also resistant to any of the fluoroquinolones. Okay. And extensively drug-resistant TB or XDR TB. Now TB is caused by M tuberculosis that is fulfill the definition of MDR or rifampicin resistant and are also resistant to any fluoroquinolones, levoflox or moxiflox, and at least one of an additional group A drug. Now the group A drugs are changed, we'll come to that, which includes either bedaquiline or linezolid. Interestingly, here the aminoglycosides and they are not included over here now when we talk about the extreme drug resistance. So extreme drug resistance is a terminology where they use is H and R resistant, fluoroquinolone resistant, and also either bedaquiline or linezolid resistance. So this is something which can change. Now this is a case which I'm going to go fast. A 29-year-old female admitted to the hospital with nausea, vomiting, diplopia, and she had a CNS tuberculosis. 7 months back diagnosed as disseminated TB, pulmonary, mediastinal, lymph node, abdominal, and TBM. And this patient was received 7 months of first-line drug. Okay, before coming to us. If you see very carefully, there are miliary nodular shadows are there. GeneXpert MTB detected rifampicin sensitive. AAB cultures MTT detected 4 weeks. DST was not performed. Okay, she was admitted in the hospital, and this was a chest X-ray, miliary shadows. The CT brain showed infective leptomeningitis with hydrocephalus, few subcentimeter periportal lymph nodes. CSA polymorphonuclear GeneXpert MTB detected rifampicin sensitive. AB culture not detected, and the pyrosequencing was also done over here, which showed that when the CSF was sent, it showed that it's completely drug sensitive tuberculosis. There was no drug resistance, but patient was behaving like a drug resistant, progressively deteriorating despite of appropriate treatment. And remember, these are a very common scenario, and where we do sometimes INH and rifampicin blood levels, and if you see over carefully, they are severely reduced levels of rifampicin and INH. This is routinely we do when patient is sensitive to tuberculosis, does not respond, and we found that there is a low absorption of INH and rifampicin in the blood. Okay, and this patient was put on the second line drugs only because it is like INH and rifampicin not going to work, and we also have given a higher dose of INH and rifampicin just to cover. And later on, we tested the HNR level with the higher doses, and they are little borderline coming to the level which is required. Okay, so we continued the second line therapy in the patient. Okay, so now to treat this patient, once we used to use injectable rifampicin and injectable INH, which is not available in our country. This is really another thing, how to treat such patients when the absorption issues are there, and we require actually the injectables in the country. Now, as well as diagnosis of TB is concerned, is some clinical suspicion, radiological, histopathological evidence, and identification of bacteria in, or a gene particles inside. So we need both in a histopathological proven diagnosis. A microbiological diagnosis is very important. Okay, so which can be done on smear, culture, nucleic acid amplification, line pro assay, and pyrosequencing, and whole genome sequencing. And some next speaker is going to touch some of these aspects. So I'm not going to go into the depth of it, but at least ideal TB test, it should be rapid, reliable, reproducible, simultaneous detection of resistance pattern, and should be cost effective. And most important thing is that it should be turnaround time for a diagnostic test should be as less as possible. You see, even that test gives around up to 7 to 8, 9 days are required for LPA, and sensitivity report for a liquid culture sensitivity report takes up to 2 months. Okay, sometimes even you may get in 3-4 weeks, but many times you can get the report at least between 8 to 9 weeks. And the liquid culture follow-up sometimes also takes much more time, around 45 days. So this turnout time gives you problem. That turnout time also is responsible for poor treatment to the patient, disease spread, and the most important thing is that in community the disease continues to spread. This is a very complex slide from the programmatic management of tuberculosis. What is very important, we're going to come to that, we have to find out whether patient has got rifampicin resistance. If the rifampicin resistance is there, then we also try to find out whether there is a first line drug resistance, INH resistance is there or not, or quinolone resistant there or not. And we've tried to find out whether in INH resistant, whether it's a INH CAT gene and INH the genotypic resistance is there, or both are there are resistant. Finally, why this is important, because we have to find out whether we can give a shorter drug regimen or not. This is the current guideline, and if you have no additional resistance detected for H and R, H for CAT gene or INH mutation, or there is no fluoroquinolone resistance, this patient will get a benefit of oral bedaquiline short course regimen. Okay. If H and R deletion is detected in both CAT gene and INH mutation is there and fluoroquinolone resistance detected, then obviously this patient will go for the prolonged therapy for that is a longer oral treatment for management of tuberculosis. This is very important. So we need detailed information about the patient. Even the patient is rifampicin sensitive is there, it's not detected. Still, we have to find out is the patient has got INH resistance or not, or is there any poly resistance is there or not. And so, in short, those group of patients today in National Tuberculosis Control Program, many times rifampicin resistance not detected, they straight away put to our first line drug, but you miss many times the INH resistant and some other drug resistant. That finally leads to if you don't detect H resistance early, then we finally rifampicin resistance also is developed in this patient, and the disease spreads. Okay, that's why that is the reason where MDR is increasing. So it is important that at the points place, first time only, if you can get a complete idea regarding the what type of resistant patient has, it helps to personalize the treatment for the tuberculosis rather than follow doing the many times you have to do the sputum, you have to send to the finding out the other drug sensitivity test, okay, resistant detection test. So this is something which is very important, and in many times the phenotyping culture is also is included in the our management, so that when the culture positive is there, we can use that culture for doing the complete sensitivity testing. So this is the current line. So diagnostic challenges is here the confirmation of diagnosis, molecular especially diagnostic with a conventional technique. Extrapulmonary versus TB, pulmonary TB has got another problem in extrapulmonary or paucibacillary disease, or even pulmonary paucibacillary disease. Very difficult to diagnose the MDR and XDR tuberculosis in them in early stage. At least in lung diseases, you can do bronchoscopic lavage and send, but the other abdominal tuberculosis or patient with the pleural effusion, etc., they are very difficult to diagnose at one point what exactly is happening to the patient. A lot of time is wasted in such conditions. This delay is very important, that we should not, we should try to prevent the delay as well as the TB is concerned in the management. So as we have, this is going to be touched by my other speaker, that it takes approximately 4 to 6 weeks to get a culture reports on the conventional cultures. And there are pitfalls in the sensitivity reports also, because many times the ethambutol, pyrazinamide, ethionamide, and even if you are doing the second line drugs like cycloserine, imipenem, salicin, meropenem, they pass. Their sensitivity pattern is not reliable. Okay, and we many times have to depend upon our empiric line of therapy when you are planning to put the patient on the second line therapy. But with the help of a GeneXpert and CBNAT technique, we can detect rifampicin resistance very fast. And in poor GeneXpert, in smear negative patient, sensitivity is around 69% with specificity of 99%. That's very advantageous, especially in the pulmonary tuberculosis. And in the smear positive patient, sensitivity is around 98%, and referred resistant detection is around 95%, and pool specificity is around 90%. So molecular techniques, especially CBNAT GeneXpert, is very useful in diagnosing pulmonary tuberculosis and point test to diagnose MDR tuberculosis. GeneXpert Ultra is a highly sensitive test and recommended by WHO, and it has got good sensitivity compared to normal CBNAT technique. It has sensitivity is enhanced to 88% from 85%, but as the sensitivity increases, the specificity goes down to 96% from 98%. So it can even detect the dead maxilla. So that's a drawback of a GeneXpert Ultra. TrueNat is nothing but a chip-based micro real PCR-based assay for TB. Basically, turnaround time is 1 hour. It is more of a, you can say, that made in India, and it is cost effective. It's cheaper compared to the other technique. Okay, and it can detect the simultaneously the resistance also can be detected very well. XDR is like GeneXpert. You can detect MDR and first line MDR as well as the second line resistance also you can pick up with this. And this technique is launched in 2020. WHO has yet to give the validation, and that is awaited. So this can also help us to change the line of management when we have expert XDR. Line Pro Assay, as you are aware that key LPAs are basically initially started for rifampicin, but later on INH and rifampicin, CAT gene and INH gene. So you can detect the drug resistance in the sputum sphere positive patient, both INH and A, this thing very easily with this technique. It require a good laboratory, and obviously biosafety is to be followed. LPA should not be used for should be used for only smear positive patient, and it is generally not used for the smear negative. And it's very important that for extrapulmonary also, when the paucibacillary, the LPA tests are not really recommended. For a better outcome of the patient, early diagnosis, finally targeted genome sequencing or the whole genome sequencing is going to be the answer. Okay, and that can help us to get an early diagnosis of the TB treatment and a personalized management of tuberculosis, which is really required when you are going to manage the patient very well, as well as diagnose them and treat them. The most important about targeted sequencing is the weakness is that knowledge of targeted is required, less information than whole genome sequencing is expensive. The strength is that sequence directly from the sample, large number of genes targeted, less expensive than whole genome sequence, simple bioinformatics, the storage, detection, rare mutations, and heterogeneity also detected by the targeted, like a whole genome sequence. The whole genome sequences have a lot of strengths. which probably we have to go and find various genes which are used in whole genome sequencing, which have got a very high sensitivity and specificity compared to the your standard phenotypic culture. And even PMDT India endorses that the advantage of whole genome sequencing, the sensitivity and specificity is concerned. So overall whole genome sequencing, overall sensitivity is 94.53% and specificity is 92%. So WHO endorses, okay, the lot of LPA gene and line pro assay and those things. And there are a lot of emerging technologies are going to be there, which are be in the future. And if you see that from smear has got a sensitivity of 69 to 69%, specificity is very high, 97 to 98. The whole genome sequences, we have seen that it gives rise to sensitivity around 92%, with specificity of 94 to 95%. So these all new technologies have improving the sensitivity and specificity of the diagnosis of tuberculosis.